Hi students, this is Dr. Tatum. This should be my last recording for chapter 19, and I'm going to start on slide 18 where it talks about electronic fetal monitoring. So as I was saying before, we use electronic fetal monitoring to assess fetal responses to hypoxia as well as asphyxia. When we hook mom up to an external fetal monitoring system, we can detect variability in the heart rate. So variability patterns, we can assess a baseline fetal heart rate, and we also are assessing for accelerations in the fetal heart tones, especially as they pertain to fetal movement. So if mom is feeling the baby move around, we want to make note of that. And that way we can see what it does to the fetal heart rate. Hopefully that fetal heart rate will go up rather than down. So a non-stress test is the most ideal way and the most popular way, really, and most common way of really assessing fetal well-being. So basically, there are no contraindications related to this test. What we do is we look at fetal heart rate accelerations in response to fetal movement. So this is done in an outpatient setting. A patient is hooked up to an external fetal monitoring system. So she has an ultrasound transducer, and also probably a toco transducer on her belly. And she's asked also to hold a handheld device with a button on it that's hooked up to the overall monitoring system. And she needs to push a button when she feels fetal movement. And basically, that will make a mark on the monitoring strip that indicates that the baby's moving around. And that way, we can look at the fetal heart rate to see if there was an acceleration pattern going on. And so usually she's hooked up to the monitoring system for about 20 to 30 minutes so we can get a good, accurate account of fetal heart tones. If baby is not moving around, maybe baby is sluggish or sleepy, we can do a vibroacoustic stimulation, which is sound and vibration to help stimulate the fetus. So it's a little device that goes over the abdomen and it basically stimulates the baby. It wakes up the baby, and a lot of times it does cause or stimulate fetal movement. All right, so we're going to move on. So if you look at this strip, this is a reactive strip, and it's a good strip because if you look at the variability, we can see that it's moderate variability, and we also see accelerations, which is a good thing. Remember, accelerations are reassuring. We always like to see accelerations in fetal heart tones. So basically, you can see that these accelerations are lasting about 15 seconds, and they peak and they last about 15 beats, or they are about 15 beats per minute above the baseline fetal heart rate, which is awesome. All right, so this is a non-reactive strip. You can see here that there are no accelerations present. A lot of times too, you can't even tell if this baby is moving around at all. So most likely this baby needs to wake up. So we might do a vibroacoustic stimulation to this baby to see if we can stimulate an acceleration in fetal heart tones. And most likely mom is going to be monitored for a while longer. All right, you can see here the variability of this strip is not the greatest. It's more minimal variability, I think. Initially, you can see a non-reactive pattern, but then after vibroacoustic stimulation, see these musical notes here, stimulate that fetal movement was felt by the mother, and now you can see fetal heart rate increasing, and you can see that there are some accelerations then afterwards. So here would be an acceleration, a minor one, but it's still there. So again, this is a reactive non-stress test after vibroacoustic stimulation. All right, moving on to a contraction stress test. This is a little bit more invasive, especially if mom is hooked up to oxytocin. But what happens is we hook her up to an external fetal monitoring device. So again, the ultrasound transducer and the toco transducer is used. And what she can do is do a nipple stimulated contraction test. So what she does is She basically rolls her finger over her nipples to basically stimulate the nipples to release that endogenous oxytocin that we have on board. And so if this works, you might see some contractions noted on the monitoring strip. And what we're looking for is um, good moderate variability. We are still wanting to see accelerations. We do not want to see any decelerations in relation to contraction pattern. And that's basically what we are assessing here. So basically, if we see contractions occurring from the nipple stimulated contraction test, then we know that fetal well-being is not great. And that gives us a good baseline to know exactly what specific monitoring do we need to do further on the baby, or do we need to get baby out sooner rather than later. So that is what a nipple stimulated contraction test is. An oxytocin stimulated contraction test is actually when we place an IV and we give her oxytocin via IV route to help stimulate or induce contractions. And again, we're looking for the same thing. So every time she has a contraction, we're looking for any decelerations in fetal heart rate. If there are decelerations present, again, that tells us that the baby is not doing well in utero. And most likely there's a perfusion issue. So if you look at letter A actually looks really good. You can see that there's moderate variability, there's some good accelerations in fetal heart rate. You can see some contractions here, but if you look at the contraction pattern, the fetal heart tones are all great. There's no decelerations present. It looks like baby's doing great. So that would be a negative contraction stress test. Letter B, however, is not as pretty. So here you can see, it's really hard to tell here, but minimal variability, maybe even absent variability. And here you can see some good contractions, but with every contraction, you can see a deceleration in fetal heart rate. So here's a contraction, and then you see a deceleration. So think about what type of decelerations are occurring here. Give you a minute. You really kind of see recurrent decelerations on this strip. It's ugly. I would say these are recurrent late decelerations. And a late deceleration indicates uteroplacental insufficiency. So baby is not getting perfused well enough. All right, so the last few slides I want you guys to review on your own. If you have specific questions over this content, please bring your questions to class on Wednesday via our Zoom meeting, or just email me. Hopefully I can help you out. All right, I hope you guys are all well, and I look forward to seeing your faces. Thank you. Have a great week.